Good afternoon, everyone. Good morning, Professor Clark. It's very warm welcome today for the webinar. Okay, I'm Dr. Olarik from Chaophraya Abhaibhubejhr Hospital from Thailand. I know that my hospital, the name is very difficult. And but by the way, it is my honor to be the moderator for today. We will talk about the outpatient hysteroscope. And today, our speaker is a professor from the Birmingham Women's Hospital and the University of Birmingham, Professor Justin Clark. He is the former of the BSGE and RCOG, and he is the key person who wrote the guideline about the outpatient hysteroscopy for the RCOG. So over to you, Professor Clark.
Thank you very much, Olarik, for a lovely introduction. So this is the second in a series of webinars focusing on the essentials of outpatient hysteroscopy. Olarik, can you see my screen okay?
Not yet, sir. Everything's only all pink.
Hopefully, yes. Okay, is that better? You can see now.
Perfect.
Okay.
Perfect.
Great. So thank you everyone for joining. Yes, good morning from the UK. Good afternoon from elsewhere. I think most of the audience from wherever you are. So in a previous webinar, I touched on various fundamentals and equipment, and in this webinar, I want to really speak to you about sort of the outpatient setting, managing pain briefly, which we did touch on last time, but concentrate a little more on potential complications, particularly those specific to the outpatient setting, because I'm aware that some of you are practicing in standalone units without necessarily lots of support, and so we'll discuss those, and hopefully I'll reassure you from that side of things. And then, as the webinar is sponsored by Macrolux, we will touch on specifically the Macrolux endoscopes and some of the interesting illumination functions. And finally, a couple of sort of case studies, predominantly around managing complications. And I may touch a little bit on quality assurance as well. So how to ensure that your practice is good and actually comparable with the best that's out there, and how you can continue to enhance your practice. So I think we would agree that hysteroscopy is important. The reason we're on this webinar discussing things today is that it's valuable not just as a diagnostic tool for fertility and malignant or pre-malignant issues, but also to allow treatment. And particularly by doing things in the outpatient setting, we can offer a safer, quicker, more cost-effective, more convenient approach. And this is why the outpatient setting has really moved on. And this has been driven not just by health service efficiencies and benefits for patients, but also demands of patients. And also it's really been made possible by advances in technologies like the disposable hysteroscopes, the miniaturization of scopes, and the improved imaging quality, as well as the ancillary technologies that allow us to remove pathologies, particularly structural lesions. So just so we understand, we're all speaking the same language. So about an outpatient procedure, I was involved with a group internationally where we defined some sort of universal nomenclature. And it might seem strange, but there are different terms around office, ambulatory, outpatient being used. So what an outpatient procedure, what essentially I'll be meaning in today's webinar, is one where it's conducted, wherever it's conducted, without the need for an anaesthetist, so without the need for general anaesthesia, which we'd refer to as level 5 pain, or regional analgesia, so things like spinal epidurals, which would be level 4. We allow sort of just analgesics or nothing, or local anaesthetic, which I'll touch on shortly, to the lower genital tract, or the use of oral conscious sedation or inhalational methods like nitrous oxide or methoxyfluorine. When it comes to parenteral medications, some units may be able to offer this, so this intravenous sedation, but in general, for a more universal definition of outpatient, we're sort of making the cutoff at what we call level 3A. So anything involves parental medications upwards. For the purpose of this webinar, I'm not considering an outpatient procedure. And typically the outpatient procedure it could be performed within a hospital setting in a specific clinic, or it can be performed in community clinics or freestanding surgical centres. For clarity, an office hysteroscopy is essentially the same thing. It's more of an American term, but really it's more an outpatient procedure, but it's done in a practitioner's sort of professional premises or office. But it's essentially the same thing. Okay, so pain control. So I would draw your attention to this guideline. It's open access. It's published in the British Journal of Obstetrics and Gynaecology last year. It's an evidence-based guideline where we've collated all the evidence around best practice in hysteroscopy, which includes pain control. And I would draw your attention to that. There's a lot of good stuff in there. In terms of contextualizing an outpatient procedure, it's generally short, particularly a diagnostic procedure. The mean time for a diagnostic procedure maybe is 2 or 3 minutes if you're not affecting a biopsy, and a fraction longer if you are taking directed biopsies. The pain overall is, we've done big studies where we've looked at thousands of women. The mean pain score is around 5.2 out of 10, with 0 being no pain and 10 being the worst pain imaginable. But the pain during a menstrual period is often higher than that. So the procedure is short. The average pain experienced is, I'm not saying insignificant, but it's equivalent or less than the worst pain experienced during a period. And the majority of women, up into the very late 90%, find the procedure acceptable and will be prepared to have that again. Now, it's important, however, that the patient has a choice and they are aware that they may experience some pain and discomfort. And in a small proportion of patients, this can be more significant, such that the procedure is not possible. And she needs to understand that she's in control. And if she does not want to proceed with the procedure at any point, then it can be stopped and it can be rescheduled in a different setting where a different level of pain control, typically anesthesia or sedation, can be offered. And I think if you've got a patient who's well informed, who's listened to, who understands that, you know, she has a choice even once the procedure has started, then you generally get a compliant patient, and you're more likely to get a satisfied patient, even if they do experience some discomfort, because they feel as though they've been well informed and they've been looked after and listened to. So with an outpatient hysteroscopy, we can, with local anaesthetic, target the parasympathetic sort of nerve coming from typically the S2, S4 nerve roots. And we can do this by injecting local anaesthetic into the cervix directly or around the cervix, what we call paracervically, so in that space between the cervix and the vaginal mucosa. However, mostly we don't need to be giving local anaesthetic because the instrumentation is so small now in diameter that cervical dilatation is not required. And so often, say, in your preoperative information, so often if your clinic letters, or we, for example, produce patient information leaflets, you can advise that the patient takes simple analgesics, ideally an hour, but at least 30 minutes before the procedure. And this would be things like non-steroidal anti-inflammatory agents or simple things like paracetamol. Again, if you are going to use local anesthetic, particularly not topical, but you're going to use directed, injecting into the cervix or paracervical area, again, warn the patient that it's they will feel some transient discomfort as the local anesthetic is administered, but it usually is very quick and takes sort of less than a minute or not longer than that. We also offer our patients inhalational methods of pain control. Again, the majority of women don't require this. Some actually want to use it in advance proactively, but the majority may ask for it reactively if they feel they need it. But again, the context is that the procedure is generally quite short. So by the time you've even set this up, you may have completed the procedure. But certainly where you anticipate longer procedures, like, for example, removing polyps or small fibroids or ablating the endometrium or removing chronic retained products of conception, where there's substantial amounts, where you consider the procedure is going to be longer than 5 minutes, so maybe 10 minutes or so upwards, then I think often offering inhalational methods in advance can be, or certainly giving the patient a choice, can be important. And this is because the majority of the innervation of the uterus is coming from the thoracic nerve roots, and so we can't really target that area, without sort of regional anaesthetics, which we're not going to use as I've discussed in an outpatient setting. And so we need to look at, as I say, pain control, inhalational, whether it's oral or inhalational, and good patient counselling, and a gentle technique, of course. So this is the sort of local anaesthetic areas. In our review, we did look at injecting directly into the uterine cavity. We looked at paracervical, intracervical blocks, and we also looked at the fundal blocks as well, where things are injected into the top of the uterus. And really, we didn't find a real difference. They all seem to show some benefit over nothing or placebo, but certainly in my own practice, I tend to use direct cervical blocks. So injecting directly into the uterus, typically, as the diagram shows there, at 12, 6, 3, and 9 o'clock. So that would be when I suppose you had nomenclature level 2 pain control. As I touched on, fundal blocks is where you can use a 5 French, so a 1.8 millimeter needle, specific needle down the hysteroscope, and you can inject that into the fundus of the uterus, with the hope of actually trying to target those thoracic nerve root fibers. And there does seem to be some benefit, particularly these are both studies looking at something called endometrial ablation, which is a potentially more painful procedure. And they did demonstrate some advantage from using this sort of block. But I would say for routine procedures, by the time you've done that and the discomfort of actually administrating that, it's not worth doing for the marginal effect. So I think really it's about, as I say, counselling, offering choice of inhalational oral analgesics. And if you're going to have problems anticipating getting the instruments into the uterus, then using some local anaesthetic to facilitate that block of the cervix, which we can get to because of where the nerve roots come from, and allow you to slightly dilate the cervix to instrument the uterus. But that's my sort of my practice. I wouldn't be someone routinely using fundal blocks. And then if we look then at level 3A, this is the inhalational stuff. And we've just been funded recently for a big trial. It will probably be a couple of years before we've completed and published it. But we've had a substantial amount of funding recently to look at something called methoxyflurane or Penthrox, which is a type of anesthetic. But in the doses it's given here, doesn't have an anesthetic effect, just an analgesic and mild sort of anxiolytic effect. It's a self-contained device, what we call the green whistle. And we're sort of looking at that to see if that can be helpful. And we're comparing that against the standard, which would be the use of nitrous oxide. So as I say, I'm not saying these things are essential in your clinic. You don't have to have inhalational methods of analgesic. I think you should have local anaesthetic available to you in the cases where you need to sort of dilate the cervix. And you should be advising patients about pre-procedure taking oral analgesics. But if you do have the facility to use something inhalational, then that would give you an extra option for you and for your patients. And this is all sort of a lot of this and a lot more is in this guideline I spoke to you about, which is open access, and you can download from the British Journal of Obs and Gynae. If you just Google GTG Green Top Guideline 59, you'll get to the link to download. So I think that's important to understand the basics, what we mean by outpatient hysteroscopy, what pain control is needed, and actually the fact that pain control isn't just about pharmacology, it's about the information you give your patients before the procedure, and the information and listening to the patient and empowering the patient so they feel as though they do have a say, they do have a choice, and they are in control. Okay. So that's the sort of first part of what I wanted to speak to you about. Now I also want to touch on complications and specifically looking at the outpatient setting. So again, as with pain control and setting a context, I think it's important we do set a context. You know, hysteroscopy is a very common and a very safe procedure. Serious complication rates are really very low. And overall complication rates, we would estimate at less than 1%. So for such a common procedure, this is very low. At least half of them, though, however, are related to entry issues. And this has been typically because larger diameter hysteroscopes have been used, which has required cervical dilatation. Most of this study is out under, looking at all types of hysteroscopy. So the majority was done under anaesthetic, under general anaesthetic. And of course, if you've got a patient who, is asleep, you don't get that sort of feedback from the patient of pain or discomfort. So potentially you can adopt a less gentle technique, so a more traumatic technique, which obviously you shouldn't, but you can understand that if you're blindly then dilating a cervix, because you're using bigger diameter scopes, the risk of perforation or trauma, false passages, is much greater. The other driver outside of problems with entry is surgeon experience. So the more I practice, the luckier I get. So it's that typical thing, as the higher caseload you are in any craft skill, the better you're going to get. And so certainly the more experienced you become, your complication rates will be a lot lower. To reassure you around entry, though, because in the outpatient setting, we're using much smaller diameter scopes. So as I touched on in the previous webinar, we're looking at something called vaginoscopy, where we don't even use cervical manipulation or use of speculums. This allows us to negotiate our way under direct vision at all times through the cervical canal into the uterus. And so really perforating a uterus on entry should be very, very unusual in the absence of, for example, very extensive adhesions, an Asherman's type syndrome picture. So with good, gentle technique, under direct vision with small diameter instruments, I think that entry injury complication rate can be almost negated. But with any sort of complication, the important thing is to adopt the sort of principles of safe surgery. So the ideal thing is to not have complications. Now, we know as surgeons that's not possible. It's inevitable. You will have some complications, but you can mitigate those risks by adopting a good technique, selecting cases appropriately, and the equipment. However, as mature clinicians, recognizing that we can't prevent all complications, then we need to be able to recognize them. And in general, you find that most of the worst outcomes from complications, surgical complications you have, are when complication has been missed and the patient presents later. And then often they're quite unwell, and then you're trying to reverse the situation. Whereas if you can recognize at the time, whilst it's horrible for us as surgeons to understand that you may have caused a harm, if you can act upon it after recognizing it, the patient will often do very well and recover very quickly. And so understanding even that heart sink moment that you perforated the uterus or you've caused more excessive bleeding, it's something that I would, you just need to recognize that. And if you recognize it, then it allows you to go on to the third point, which is knowing how to manage that situation and rectify the situation. So these are the main risks of hysteroscopy, and this is all types of hysteroscopy, but I will sort of concentrate a little more on the outpatient setting as the focus of this webinar. So let's start with pain. So this obviously isn't an issue if you're doing things under general anaesthetic, but in the office setting it can be. Now I've touched on pain control, and it's a very acceptable procedure with good levels of pain, minimal pain, and as I say, it's a short-lived procedure. Very occasionally, however, you may complete the procedure in a very atraumatic way, uncomplicated way. The patient may be tolerating it extremely well, but then you might find they have significant pain once the procedure is finished. Now, this isn't common, but I have certainly had patients like this. And your first thought must be, well, even though I think it was straightforward and uncomplicated, is it possible something serious has happened? Have I perforated the uterus, particularly if you were doing something operative using mechanical or electrosurgical equipment? Could you have caused some visceral injury or whatever? Why have they got so much pain? But to be honest, if it's a straightforward procedure, it often is just acute uterine spasm, which can lead to quite significant pain. So in this unusual situation, but you will be faced by it, the important thing is to assess the patient, make sure that they've got a soft abdomen, that their vital signs are fine, and reassure yourself that you haven't done anything terrible. And then I think in this situation, it's better to get on top of that pain control quickly. And so it's about of giving some sort of opiates, typically something like morphine, early. You can give it orally, but ideally parenterally, and allow them somewhere to recover, somewhere on a reclining couch, or if you have access to a trolley or bed, allow them to have a period of observation for the pain to settle. And it should do within the next hour or so, and then you can discharge that patient. So I don't want you to think that that's a very common thing. It's not, but if you do get very acute pain, then you do need to exclude a problem and then manage it promptly with get on top of that pain with good pharmacological analgesia. The other thing that's sort of unique, well, not quite unique, you can still get, I suppose, vasovagal reactions with an anaesthetic, can't you? But particularly in the outpatient setting, if you are stimulating the cervix, because those parasympathetic nerve roots can, that autonomic, you get a fainting episode of vasovagal reaction, as a result of dropping blood pressure, dropping heart rate, and then as a result, hypoperfusion of the brain, which can lead to the classic symptoms, of clamminess, sickness, vomiting, anxiety, feeling faint. And I'm sure probably in your respective countries, you may have certain algorithms. It would be very unusual for someone to go into asystole. I would reassure you that touch wood, in my whole career, that's never ever happened to me over 30 years, sorry, of hysteroscopy in the outpatient setting. But there are algorithms for a sudden onset of bradycardia. But generally, a vasovagal reaction can be managed supportively. So to minimize the chance, so we talked about prevention and recognition, to minimize the chance, then offer a very gentle approach. Try not to dilate the cervix, and that will minimize stimulation of the cervix. It's often obvious, but having said that, you might have a patient who's got changed, who comes to sit with you, you explaining what you found, what the management is, and you can see the colour physically drain from their face. You saw them before the procedure, you've seen them after, and there may be pallor there, or should be cognizant of the fact they may not be listening to you very well. In which case, there's no point carrying on the consultation post-procedure. It's better to allow them to lie down if that's possible. Certainly get their heads between their legs, but ideally lie down so that they can perfuse their brain. Give them some fluids. So oral fluids will usually suffice. It's very unusual you'd need to put an IV cannula in. And provide reassurance and comfort, and if pain control is needed, some pain control. And you'll often find that this will settle very quickly. But if you typically get a patient who's pallor, who's clammy and sweaty, sorry, my slides are advancing, being sick, feeling sick, or actually being sick, and feeling faint, this is usually an obvious sort of diagnosis. And if you just take their pulse briefly, you'll see that they're bradycardic. And usually that will settle, as I say, with just supportive measures and reassurance. However, if you do find, obviously I should say as well, if this happens, I was sort of talking about a post-operative sort of situation, but if it happens perioperatively, then it's a good idea to stop the procedure. And if the patient's on the couch in lithotomy, if you adopt a Trendelenburg position, reverse Trendelenburg position, then you can and get the legs up, then you can help even more so perfuse the brain. Of course, you need to be careful if they're being sick, in which case you're probably better putting them in the recovery position and lying them on the side. It's very unusual. I have occasionally, but not very often, had to use antimuscarinic agents, so things like atropine or glycopyrrolate to treat the situation. But this would really be quite unusual. And as I say, in that previous algorithm I showed you about CPR because of asystole, touch wood, never happened to me. And I'd reassure you that these vagal reactions, depending on how you define them, how liberal or how extreme you define them, let's take a level of 5% it could be. But these are all mild, self-limiting, as I say, not something that I think you need to overly worry about, but you do need to manage that. And again, for patient satisfaction, make sure you listen to them and offer them a recovery area. So some form, oh, sorry, it's just going forward. Some form of recovery area, I think ideally is important. Not even with an uncomplicated procedure, because it does allow the patient to feel cared for, give them some fluid, drink afterwards, allow them to recover. What you don't want is the patient coming in, having an intimate, potentially painful procedure, and then being thrown back out onto the street and feeling that they've been treated, like a piece of meat sort of thing. It's important that the nice thing about outpatient procedures is it's a procedure, but we can offer that wraparound care as you would with a standard consultation. Good consultation preoperatively, good communication and technique perioperatively, and then good care post-operatively, whether they've experiencing pain or complications or not, so that the patient feels very well looked after, and they'll give you good feedback and good satisfaction. So acute pain unusual, vasovagal is quite common. What about a trauma then? Well, hemorrhage, again, in the outpatient setting, thankfully, it's unusual because you are limited by the patient being awake, regardless of what analgesia you get. And I think you shouldn't really do procedures in the outpatient setting beyond 20 minutes. The majority of procedures, as I say, diagnostics would be less than 5 minutes. A therapeutic procedure is usually less than 15 minutes. So I think that if you're offering procedures beyond that, then I think that you have to ask, well, is this really appropriate for the outpatient setting? Will the patient tolerate that? Certainly with feedback from patients, the patient's awake, it's sort of quite hard to perforate a uterus or drill into a false passage and cause bleeding and trauma without really you being aware that this, from the patient, that this isn't going how it should be. But sometimes you can use some mechanical instruments, you can, get some significant bleeding, but in general, this is, easy to see, and you just got to understand where's the bleeding coming from. So if it's often obvious it's coming from within the uterine cavity, but sometimes it could be from if you've instrumented the cervix, or you've even administered some local anesthetic. If you're unlucky and you've hit a vessel, you can get some bleeding. But understand where the bleeding is coming from. Usually simple tamponade will resolve the situation, whether it's a puncture site, or if you've inadvertently avulsed a little bit of cervical tissue. So put some pressure on. You can sometimes use silver nitrate or what we call Monsell solution, some ferric substance, to try and stop any bleeding on the cervix, or sometimes, rarely, a suture if you have avulsed a bit of cervix. But in general, because we're adopting a vaginoscopic approach, we're not routinely dilating the cervix. And certainly if we are dilating the cervix, we're not putting huge resectoscopes in. We're using equipment typically of maybe up to 6.5 millimeters. It's unusual that you're going to cause significant trauma to the cervix, but it's possible, as I say, manage it in the way I've discussed. If the bleeding is coming from higher up within the uterine cavity, again, always say to yourself, is it possible I've caused something more significant, typically a perforation? But generally, if you conducted the procedure under direct vision, and if you've had bleeding during the procedure and you've been unable to rectify it with changes in irrigation and pressures within the uterus, then you should have abandoned the procedure. So never operate without vision. And then if that's the case, even if you have bleeding, you can be confident that you haven't caused any significant trauma. Okay, so I've touched on the cervical laceration. In terms of like the equipment I was talking about, even if we're using operative equipment, these sort of endoscopes now, whether it's electrosurgical ones or whether it's small mini resectoscopes or these tissue removal systems, we essentially are using systems that ideally are 5 millimeters or less. So they're 5 French tap channels where you're putting, 5 French 1.8 millimeter or so scissors and graspers, etc. down. Or with the tissue removal systems, they can range from between 5 and 6.5 millimeters. And again, they allow the simultaneous cutting and aspiration of tissue. And I say in a subsequent webinar, I can show you some procedures. So these are small diameter equipment suitable for the outpatient setting. And this is why I'm saying to you, the idea of causing trauma should really be quite low. Some people ask me about cervical preparation. I don't think you need to routinely give prostaglandins because we're using small diameter hysteroscopes. That said, though, if you have got a patient you anticipate or in advance has a history of cervical stenosis, maybe from previous cervical loop biopsies or a previous procedure that was abandoned, then you could consider in those cases administering some vaginal or oral prostaglandin, ideally 12 hours before the procedure, but certainly a minimum of 3 hours before the procedure. But I certainly wouldn't do that routinely. And I think we talked about management. Now, perforation, again, try and minimize, prevent that, avoid unnecessary blind dilatation. Be aware of the potential risk factors. So this would be, we're all aware of, women who have not had vaginal deliveries, women who are in the postmenopausal estrogen deficient state, if you have an acute version or axis of the uterus, and if you've had previous cervical procedures, so biopsies, or known uterine anomalies or acquired adhesions, then an experienced operator should be doing these things, and we should be definitely doing them under direct vision. It's important you understand your hysteroscope, so you understand if you're using an offset lens or not. So you need to then, as we discussed, I think in the last webinar, line up the hysteroscope correctly. And again, that will minimize the risk of perforation and going the wrong way, creating false passages, and maintain a clear field. If you do have a perforation, then often you will recognize it because you will see filmy, what we call cobwebby type tissue, which is as you go through the serosa. And if you start to see yellow material, this is generally fat around the bowel. And so that is abnormal. So, you need to stop and recognize the situation. If you are using a fluid management system, this is more typically in a theatre setting, particularly if you can suddenly get a sudden loss of fluid. And again, that may indicate that you've made a hole in the uterus and it's going into the peritoneal cavity. But as I say, to reassure you, in the outpatient setting, this is unusual. You're using smaller diameter equipment under direct vision, and the patient will tell you if you're starting to go through the uterus generally. So if you manage it, I would say that if you have just bluntly, you've gone through with either a dilator or with your hysteroscope, or for that matter with some ancillary, some graspers, but you haven't actually operated anything sharp or electrosurgical, so you haven't activated your tissue removal system or activated the electrode or used your scissors before you've recognized the perforation, then I think you can simply abort the procedure, give broad spectrum antibiotics, observe the patient for an hour or so, and as long as they're not bleeding and they're comfortable and there's no signs of peritonism, you can reassure them, allow them home, give them antibiotics for a week, but what we call safety net them. So make it clear that if they do have any ongoing pain or bleeding or fever or feel unwell, they contact your clinic directly and you can manage that situation. But generally, as I say, this is something that's managed very simply without any problems. I think the issue is where you have used or activated energy or used mechanical equipment, and you're not sure that you've recognized that quickly enough. Then again, you can still manage them, in the same way with observation and safety netting, but I think you should have a much lower threshold to consider whether you need to consider surgery, particularly in the form of a laparoscopy, to exclude intra-abdominal bleeding. Do we need a stitch? And has there been any injury to surrounding structures, particularly bowel? To be fair, to reassure you again, though, this is far more likely using bigger diameter equipment, typically resectoscopes, when you're operating on fibroids, and that would usually be in a theatre setting. I'm not really going to go on about fluid overload because my focus was really on the outpatient setting. And as I say, unless you're using prolonged procedures or removing deep fibroids, it's very unlikely you're going to cause significant fluid overload. And because those procedures are generally for the OR setting. So I'm not really going to dwell on that, but just be mindful of the fact we should be using saline, so physiological conducting media, because most of our equipment is mechanical and doesn't require a particular distension media. So we may as well use something physiological. And most electrosurgical equipment now is bipolar. So again, you would be using a conducting media like normal saline. So it's unusual you'd be using sorbitol or glycine in an outpatient setting because of using monopolar energy. But if you are, then obviously just be mindful of your fluids. But I think really, for the reasons I've outlined, fluid overload, again, in 30 years of doing this, I've never had any sort of problem like this in an outpatient setting. There are guidelines available. So I authored the joint BSGE ESG guidelines, which I think does need an update, and we are looking now at collaborating globally to update those guidelines. But again, if you wanted to sort of educate yourself on fluid management, particularly if you're doing significant procedures like fibroids in the theatre setting, then I'd draw your attention to that. Again, open access, and it sort of goes through how to manage fluid overload, and if you are using non-conducting media, how to manage hyponatremia. As I say, this would be very unusual using physiological media. So electrosurgical complications. I think in the outpatient setting, we can use electrosurgery, but there's no two ways about it. The studies certainly I've been involved with, where we've randomized between electrosurgical equipment and the tissue removal systems and mechanical systems. The mechanical systems seem to be less painful, quicker, and more acceptable. But if you are going to use electrosurgery, which is absolutely fine, again, because you're using energy, you need to avoid non-target injury. And so this is important to always do the procedure under direct vision with clear views. Recognize that if the perforation has taken place, don't panic if it happens. It's a bit like I should have said in the last slide about perforation. What the junior doctors often do is they see it, they pull it away, they panic. That's the wrong thing to do. When you're there, look, advance the scope. If you can see yellow, understand, have I caused bleeding? Is there anything else I've done? And sort of take a look. So assess the situation, but certainly stop activating the energy. And the management there is as for what I touched on with perforation. We've done studies of vaginoscopy versus standard approaches where we've used antiseptic. So with vaginoscopy, typically we don't. We just enter the hysteroscope. But we did a big randomized study of 1,600 women where we randomized between that and the use or using speculum with antiseptic solution. And we found no difference in infection rates, and these were extremely low. And so I think it's unlikely, the risk of endometriosis or ascending infections is low. You tend to see it more in procedures, say, for example, an endometrial ablation, where you've actually purposely destroyed the endometrium, or procedures where there may have been a false passage created or something. You may be more likely to develop an endometriosis, but it's very unusual to develop things. But of course, it's possible you could end up with a woman representing in a few days with a fever, bacteremia, and often this resolves quickly with intravenous antibiotics. But sometimes if they've got pain, you should exclude an ascending infection, and particularly a tubo-ovarian abscess. So that will be with imaging or CT scanning. But again, to reassure you, those risks are really very low. Okay, just to finish off then, I think we've talked a little bit then about pain control, about informing the patient, and then about managing situations where there's complications around pain, fainting, or trauma, or infection. But again, I reiterate that these risks are much lower in the outpatient setting, and I've never had, touch wood, a severe complication in the outpatient setting in many years of performing the procedure. But if you want to know and reassure yourself that you're doing a good job, or for that matter, if you want to actually improve your service, or you have some concerns about your service, then certainly quality assure. There's an audit tool with reference standards we presented in this, which is evidence-based in this guideline I referred you to at the beginning of the talk. You can compare yourself. We published a series of 5,500 cases from across the UK from 77 centres, so a generalisable study where we looked at, for example, here, a whole range of things: preoperative, perioperative, and post-operative satisfaction. But this, we looked here at pain control, and you can see that the confidence limits are really very narrow because we have a sample of over 5,000. And you can see the mean pain for whether you're doing a diagnostic hysteroscopy with biopsy or putting coils in or removing a polyp are all pretty similar. They're around 5.1, 5.2. If you perform myomectomy and ablation or removal of RPOC, they're a little bit higher, although the numbers in those groups were smaller. So the confidence limits are a bit wider. But again, you can compare yourself if you were to collect pain scores in your own clinic to see whether you're doing better than this, the same as this, or if you are worse than this, then you, rather than be defensive, you might say to yourself, well, what's the reason? Is it the operators I've got in my department? Is it often the support staff, or is it the equipment? Have you got not the latest technologies? Are your hysteroscopes a little too large? Are people not adopting vaginoscopic approaches, etc., etc.? So this is a good way of looking at, are we doing well? Can we improve? And we should all be seeking to improve. We also have a best practice paper that I authored, again, which is slightly different from the guideline, but does sort of give more practical advice. And again, this is available off the RCOG website, open access. And this is also just to show the audit tool again, which is open access from the guideline I showed you earlier, the British, the evidence-based guideline, which shows the sort of rates that you should be looking at in terms of success rates, vasovagal reactions, etc., etc. So you should compare whether you're meeting those sort of standard, those average rates. Finally, on the Macrolux system, because I'm very grateful Macrolux for sponsoring the webinar. These technologies, and we'll touch some procedures in a subsequent webinar, but these technologies are really important. It's really impressive that it's so small, it's so light, it's so easy to use, and it's disposable, and the image quality is very good. And it offers you bespoke outpatient technology for not just diagnostic procedures, but also for operative procedures, which is very useful to use your mechanical instruments or your electrosurgical equipment. And certainly the hysteroscopes are small diameter, which again allows that vaginoscopic approach and without the need for cervical dilatation. And whilst 0-degree scopes, they do have an end that can be manipulated and moved, so you do have a wider field of view to allow you to access particularly the corneal aspects of the uterus. And as I say, the image quality is very, very good. So you can detect your endometrial abnormalities, your structural abnormalities, whether they be congenital or acquired. I just want to touch a little bit just on some of the imaging things around the Macrolux system. So they've got three sort of modalities that you can use in addition to white light, which would be the CIAM mode, the amber mode, or the limpid mode. And I'll just touch on a little bit, the differences between these. So light gets absorbed of blood vessels, I should say, absorbs light of the blue and green wavelengths much better than of, for example, the red wavelength. And so by doing that, you can set a mode where by absorbing this light, this frequency of light more effectively, you'll highlight the superficial blood vessels a little more. And I'll show you an image of that. The amber mode is essentially the same thing, but with actually overlaying some software over it to get a sort of more amber color effect, again, just to enhance, in this case, sort of submucosal hemorrhage and blood supply. So it allows you, it's a bit like the Firefly system or in laparoscopic surgery, allows you to give you different sort of views that might allow you to improve your diagnostic approach. And then the limpid system is essentially somewhere where it's trying to sort of clear. Sometimes you can get like if there's intracavity fluid, particularly in older women or debris, you can get a sort of turbid appearance, which hopefully will clear with irrigation. But this mode allows you to sort of bypass that sort of turbid appearance and get different views. So to see here, you've got these typical white light on the top left, but then that CIAM mode, you can see how it sort of highlights the blood vessels, the superficial blood vessels. And again, this might allow you to sort of understand whether there's a degree of, for example, endometriosis here, driving problems, or looking at the vascularity of the endometrium. So is it more likely to be a hyperplastic endometrium or a hyperplastic polyp, for example? Then you have your amber mode in the bottom left there, which again showing this submucosal hemorrhage, and then the limpid mode, which is allowing you to clear a sort of cloudy, turbid condition. So these are things you can play around with that can be useful with the Macrolux system. Now, I know I think I'm running out of time, so quick case study. I was asked to give a couple of case studies, so very quickly, let's look at pain control and vasovagal. So a 32-year-old, non-gravid woman, so tight cervix, she's diabetic, so she's got some risk factors. BMI 20, often women with a low BMI often run a healthy, lowish blood pressure, and from anecdote seem to have a higher propensity to vasovagal responses. Vaginoscopy, but with a 5mm scope, which is fine, but it's a slightly bigger diameter scope. So these are all things that might trigger cervical stimulation and vasovagal responses. I've said they're an uncomplicated procedure, so we're not worried we've caused any problem, but after the procedure, she's clammy, pale, and fainted. So we should easily recognize this is a vasovagal reaction. Yes, think of the worst case scenario. If she's an older woman, or in this case she's diabetic, could be a hyperglycemic episode. Could it be something cardiovascular, particularly say in older women with a cardiac history? But in general, it's going to be a straightforward vasovagal. And as I discussed, lie the patient down. If they're also on the couch, get their legs up, and give them some oral fluids, sometimes IV fluids, but that's usually not required, and monitor them, take their pulse, use a SATS probe if you have one access. In this woman's case, I'd check her blood sugar because she's diabetic. And very rarely you need to give things like atropine. More often it's analgesics you need to give. If we continue with this case and we say, oh, she recovers, her blood pressure's better, but she's still a little bit tachycardic. Well, she's still tachycardic. That's generally because of pain. She's got rolling, cramping pain. Again, explain to yourself this disproportionate pain. Have I caused any problems? It's probably acute cramps, but put a hand on her abdomen, make sure her tummy's nice and soft. There isn't intra-abdominal bleeding or peritonitis. And again, manage that patient supportively with observation, analgesics, and admit for observation. And once the patient's recovered and allowed home, because they've behaved slightly outside of the normal, then safety net them and say any issues in the next 24 hours or the next few days, get back in touch. This case I want to show is, let's say, would be an older woman who's had a very tight or difficult access into the uterine cavity using a small diameter scope, and there's been some forward movement to get through the uterine cavity. Now, in that case, the risk of perforation is higher because it's been more forceful and it's been a difficult entry. Now, the case on the right, the perforation here, I was struggling to find one. Touch wood, I don't have many, but this one's actually from an Ashman type syndrome. But for the purpose of this case report, what I want to say is that if you start to see cobwebby appearance or yellow, then this is generally abnormal. And again, this will show you here, this is a perforation. You can see that sort of thinnish tissue. I'm not really demonstrating so much the cobwebby type tissue, but you will see that if you're going through the parametrium. This is going through the fundus of the uterus. And you got then a view of the yellow appearance, which is basically epipoica, is fat around the bowel. So if you're seeing that, then you should understand you have perforated the uterus. And this is a case of quite severe Asherman syndrome. But clearly it's a tubular cavity and I've gone too far up. So recognize that, stop the procedure. Could it be anything else? Well, occasionally you can get yellow necrotic tissue of a degenerating fibroid or in some polyps, or it could be a false passage where you're creating filmy adhesions or you're drilling into the endometrium. So you may not have perforated the uterus, but in general, if you're seeing what I just showed you there, that's a perforation. Recognize it, assess there's no bleeding, manage the patient, antibiotics, observation, painkillers if they need it. And then if you've not activated energy or mechanical equipment, then I think you can safety net that patient and allow them home. But if you have activated energy or equipment, obviously if the patient's asleep, it's easy enough to put a laparoscope in. The problem with the outpatient setting, you'd have to make a proactive decision to admit that patient. So I think you can manage them conservatively if you feel that you recognise that complication early, but you must safety net them. But if you're not sure or you feel you didn't recognise it, then I'm afraid you are going to have to arrange for that patient to have a laparoscopy. So to conclude, hysteroscopy is valuable both in diagnosis and therapy now in contemporary gynecology. To do it successfully, you've got to have good imaging and visibility. So things like I showed you there with the Macrolux system, small diameter hysteroscopes to minimize the risk of trauma. Be proficient and safe, proficient and efficient. The more cases you do, the better training you have, the better you'll get. And this will minimize pain if you can adopt an atraumatic technique. It will minimize the risk of complications. And then to actually have an exemplary service, adopt some of the tools I've shown you there, the audit tools, to sort of quality assure everything that you're doing. And you can educate yourself with books. This is a book that I authored with edited, which I draw your attention to. And there's a version in China translated, but there are other books out there. But these things can be useful as well, or online materials that I've referred to. Thanks to Macrolux for some of those slides around the digital chroma functions. And thank you very much for listening. And if there's time for questions, I'm happy to take them, Olarik.
Thank you very much, Professor Clark, for your very excellent talk. Very comprehensive, and I think it's very useful. And there is some questions she wrote in the chat box, And
Okay.
I'm not sure you can read it or not from Bella.
Yes, I can. Yeah, I can. Yes. So well, you asked me, Ulrich, if I have experience of complications. In the outpatient setting, the most serious complication I've had in my career was in theatre with a fibroid resection, was with significant fluid overload and pulmonary edema, which thankfully did resolve. Um, but uh, but that's why you need to use a pump and a tissue management system. And in that case, this was years ago, we weren't, and we hadn't, and the patient was quite petite, and we'd got a deficit of 3 litres, but she developed pulmonary edema. Now that serious type complication, I've certainly perforated uteruses, don't get me wrong, but generally you can manage those conservatively. But most of those are in the OR with bigger diameter equipments. With typical outpatient procedures, the risk of serious complications, touch wood, I've never had one, but I certainly have had some pretty profound vasovagal responses, which required a management. The odd case of very acute pain, but no, I've never really had a significant problem with significant bleeding or a significant perforation. I'm not saying it can't happen, but I think it's much. This to reassure the audience with smaller diameter equipment in a patient who's awake who will give you immediate feedback. And to be fair, you're not going to be doing the complex cases like fibroid
Mhm.
resections or dense Ashman's. The risk of complications is really very low.
Yes.
So that I would say with that, Ulrich. From Bella, so for clinicians with prior operating theatre experience, how many outpatients are needed to feel confident? That's a good question, Bella.
Yes, very good question. Actually, it's the same question that I want to ask you. Okay. When we can move from the OR to the outpatient, it's very
Yeah,
difficult, right? It's very difficult.
yeah. I think. Do you know what? It's funny. Uh, I found in my career it's far easier to train my juniors who do it regularly than my peers, my older colleagues, because we all get set in our ways. So
Yes.
when I learned hysteroscopy as a junior doctor years ago, it was in theatre. We just were told, "Oh, dilate," and then
Yes.
push the scope in, and it was all
Yes.
red. And if we couldn't see, just do a DNC. So my training wasn't the best. This is years ago, I hasten to add.
Mhm.
Now the technologies have moved on and they're smaller. If you start in the outpatient setting, which I think is better, you have to adopt from the get-go a good technique, an atraumatic, under direct vision, vaginoscopic technique. And then you understand manipulation of the scope, offset lens. And then if you translate that to the inpatient setting with bigger diameter scopes, you're going to be gentler, even if you're dilating and the patient's asleep. The problem we have, as you say, is a lot of us move from an approach we've developed successfully in the OR, but that's not always going to work. Now, to reassure you, if you're used to offset lenses, manipulating scopes, doing operative stuff, that side you'll find easy in the outpatient because you can do all that. The junior doctors have to learn that, but you can do all that. But where you've got to really train yourself is that patient's awake. So just shoving in things to swab out the vagina, that's going to cause pain. The patient's going to get anxious. Even
Mhm.
clumsy manipulation of the cervix. Again, you get this snowball effect. The patient gets more and more anxious, and then you're fighting against an anxious patient. So everything you do has got to be gentle, atraumatic, and efficient. But what will help you is small diameter scopes, good bedside manner and patient counselling and information giving, and a good team around you. So nurses that are very empathetic, that can help support, can provide you with equipment you need so the patient's not exposed for longer than they need to be. A nurse that can reassure and patient, ideally, say, hold their hand and stuff. So it's not just about you, I would say, when it comes to numbers. You are very important, but it's part of the whole infrastructure to be successful, and that's more important than the OR. In the OR, you can put the radio on, you can have a team that aren't very good with talking to patients because they don't need to talk to the patient. So I think if you've got that structure in place, and if you're doing outpatient procedures, sorry, you're doing hysteroscopic procedures in theatre, I don't think you need many, Bella. I would say typically if you're starting like your junior doctors from the get-go, I would say you need to do 50 procedures
Mm.
indirectly supervised um, uh, uh, around diagnostics and biopsies. And then once you get comfortable with that, then using tissue removal systems, maybe you need to do 10 indirectly supervised procedures. But I think if you're doing it in the OR regularly, you may actually need to do less procedures. The main thing is understanding vaginoscopy and how to get into the uterine cavity in an atraumatic way. Once you've mastered that, then you know the tech, and maybe if you're not using the technologies that you've got on the outpatient in the OR, I mean, you can use all the tissue removal systems at miniature electrodes in the OR. So if you're using them already and you're familiar, then you'll, within 20, 30 cases, you'll be absolutely fine in the outpatient setting. But if you're not using those technologies, so they're new to you, or if you've not really done hysteroscopy before, then I would say 50 indirect, probably Olarik. But it varies from person to person.
Okay, there's another question is this. Do you think that we need the pump at the outpatient setting?
Yeah, that's a good question as well. So I know some colleagues who do have pumps. I don't, okay? I certainly do for in the OR. So you need to have a pump for complex surgery, so fibroid resections, Asherman's, that sort of thing. In the outpatient setting, because these are short procedures, you're generally not going to overload the patient. You're not going to be using high distension pressures anyway, because again, that will cause discomfort and pain for the patient. We're typically taking direct biopsies or removing avascular products of conception or removing polyps. And these things aren't really associated with significant problems with visualization, requiring more sophisticated irrigation systems. So my honest answer would be no. I think if you are going to start doing, say, for example, fibroids in the outpatient system, the problem with the fibroids are small fibroids we remove with small electrodes or tissue removal systems. But I think once you get in slightly bigger fibroids, sort of beyond 1.5 centimeters, particularly if they're deeper type 2 fibroids, you're going to get bleeding. The patient's not going to tolerate it well. It's going to take a long time. They're going to need some form of sedation. Now, some people do offer parenteral sedation, propofol or IV opiates in the outpatient setting with a sedationist or an anesthetist, in which case, then I think you probably do need a pump if you're going to be using, doing more OR type procedures in your office setting. But I think if you're using the defining the outpatient setting as I was defining it to you, level 3A, so no pain control, analgesics or local anesthetic or something to breathe some gas, then I think, and you're doing procedures less than 20 minutes, I don't think you need a pump. I'm not saying it's a bad thing. If you can afford it, great, but you've got to pay for the tubing and you've got to pay for the pump. But if not, I don't think you need it.
Sure. And I think this is the last question from my colleague, Dr. Passamar. He wrote a book about the congenital anomalies of the uterus in Thailand. Okay. He asks about, but sometimes the congenital anomalies of the uterus, the os is very small, very, very small, smaller than the scope. So how you deal with that?
Well, that's a good question. So I more typically the scenario with that is when you get either a postmenopausal woman, often with fluid in a cavity, and she's quite old. That fluid is because she's got severe stenosis of the cervix, or younger women who've had big loop biopsies for stage 1A1 cervical cancer or whatever, and they're trying to get pregnant, and the fertility specialist can't do embryo transfers, and you get an absolutely tight cervix. So I see it more that than with the congenital anomalies. I agree. You particularly like double cervixes, you might find one goes in easily, one's like tiny. So to take this, the first scenario I was talking about, the scarring, or either through age and estrogen deficiency or through loop biopsies, generally what I do is I either use an electrode or hysteroscopic scissors, or you can put a speculum and use a little scalpel blade or scissors to look where the dimple is. So stabilize the cervix, make sure that is where the dimple is, actually physically make a cut of maybe not more than, I don't know, less than 0.5 centimeter at least, just a few minutes. Because then if you can get the tip of your small diameter hysteroscope in and then rock it, you'll see the dark dot of the light being absorbed in addition. And then you can confidently sort of mechanically push the scope, like sort of using it like a dilator, but going in the right direction. And that works, I can tell you, very successfully. But you need to be bold and make that initial incision. In this question about congenital anomaly, presumably there's not scarring as such, it's just a very small opening. Well, that's a good question. I think I would use the smallest diameter hysteroscope I have. If I use, in this case, I may need to use a speculum and to put something, a tenaculum on the cervix to stabilize it, to allow me to use a bit more force, but ideally under vision. So I've always got that dark area in the middle of my picture or offset according to the scope I'm using it, making sure I've aligned the scope properly, and then using that sort of mechanical force but under vision. If that fails, then I think you probably have to examine, possibly use ultrasound and dilate, you know, to allow you to get the scope in. But I think those would be my approaches.
So that means you always have the ultrasound machine beside in the OR or at the office, the
Yeah,
ultrasound.
well, yeah, no, not to be honest, not always. But there is this. I mean, they've reinvented. But there's a popular thing in Europe that I'm calling things digital clinics, which is essentially yes, having your ultrasound machine and your endoscopic stack almost together, and you can sort of do your scan, render 3D images, and do it all together. And I think particularly doing a lot of congenital anomalies or operatives, I think that's a good approach. But no, I don't think you routinely need to have an ultrasound because these cases are quite unusual. But I think ideally, if you can scan and you do have access to a portable scan machine, then having that in your office, I think, is an advantage. But I wouldn't say it's mandated. I think you could have a very successful practice without investing in an ultrasound machine. But I think the gold standard would be to have one, yeah.
Okay, perfect. And because of we run out of time, so Professor Clark, please say something to the audience for the next episode because we will have the webinar maybe 4 or 5 or maybe 10. It depends. It depends on your time.
It may just be one more, possible. Maybe it was one more, possibly two. But next time, so we've talked before about the equipment and the fundamentals. We talked about pain control. We talked about complications. So next time I'll run through some procedures. So it'll be a bit more sort of video based, and we can discuss then approaches to common procedures we may do in the office setting.
Okay, thank you again, and thank you for all.
Thanks to everyone for joining, and have a lovely rest of your day. Okay, bye bye.
Okay, สวัสดีครับ บ๊ายบาย
Bye bye.
再见